Well, thank you, Dr. Hammond. Absolutely typical of the modern NHS. You wait for weeks to see your GP and he tells you you've got 10 minutes. Now, I do hope that I will be this morning treated with dignity, compassion and respect as I try to outline some of the thoughts that occur to me in the early months of the chairmanship of the National Commissioning Board. Nobody in the room underestimates the challenges that lie ahead of us. We have the challenges of demographic change, of an increased population in England over the next 10 years, with particular growth at the low age levels and at the high age levels. We have the challenges of success in medical care, driving greater investment and greater expenditure, but also leading to much more significant longevity, to a phenomenon in which people are more likely to die with long-term conditions than of killer conditions. We know that these trends are also accentuated by the growing incidence of non-communicable disease, by the close relationship between the growing trend towards obesity and type 2 diabetes, the continuance of a 20% rate of smoking amongst the adult population, and the rising trend towards alcohol-induced disease. And all of this at a time when there's no more money. We're expending between 8 and 9% of GDP in this country on healthcare. The Americans, as always, are in the lead on 18%, approaching 19%. Curiously, the percentage of GDP spent on healthcare rises during a recession because GDP goes down, and our percentage that goes on healthcare remains invariable. Against all of that, there is an enormous challenge to produce a new approach to healthcare through a modernized NHS that focuses on a patient-centered, clinically led model. This requires not only the very significant changes that the Health and Social Care Act will bring into effect, but also, as Phil has already mentioned, a profound cultural change across all of those engaged in this mission. Let me outline very briefly what is the role of the National Commissioning Board and what it involves. First, don't underestimate the huge structural transformation that's implicit in this board. It is the first time since 1948 and the creation of the NHS that the political power for the day-to-day operational management of the NHS is being taken away. The operational management is being transferred to a board on which the majority representation is of lay, independent members. The relationship with the government is completely transformed. No longer does the Tredegar bedpan rattle down the corridors of Richmond House. The assumed new relationship is that the Secretary of State will annually produce a mandate specifying outcomes across 5 principal domains, which the board is expected to deliver through its relationships. We will commission primary care, we will commission specialist care, but above all, we will work with clinical commissioning groups. Whatever goes in that mandate will also be the watchword for the CCGs. Now, I make the point critically today because there is a tendency for mandates like rolling stone, or like snowballs, to grow and grow and grow and to become almost unintelligible, weighted down with the expectations of various government departments and laden with process. What we want is criteria. We want to be able to lead with CCGs and with all the other actors in the NHS a system which is evidence-based and whose success is measured not by political popularity in different constituencies, but overall by driving improvements in health outcomes across this country. With the CCGs, we will be going through the first round of authorization shortly, and we anticipate that there will be 4 batches through which CCGs will come. Phil referred to the assumed tension between earned autonomy and assumed liberty. I don't want to play with the different expressions, because it seems to me that there are one or two fundamental issues regarding CCGs. The first is that this is a colossal transfer of responsibility. Many of these CCGs are already demonstrating in fledgling form their capability to transform the quality and reduce the price of healthcare in their areas by being highly innovative in the way in which they relate to secondary providers and to social care. Others will find the transition more difficult and more challenging. We, as the National Commissioning Board, have the responsibility to oversee the authorization of the CCGs, and we are committed to ensuring that all parts of the country will be covered by established CCGs with effect from 1st of April next year. That secondly, conditions may be imposed by us, but they're minimalist and they will be transitional. We want to be true to earned autonomy or assumed liberty in transferring responsibility and accountability that goes with it to the new batch of CCGs. I see our relationship with them as breaking down into two principal elements. One, a strong sense of partnership. Already we are working closely with CCG leaders in various aspects of our own organizational design and in the appointment of our national director team. Partnership leads also into support. We will not have a headquarters of the National Commissioning Board. There will be a national support centre. There will be regional support centres. There will be local support centres. But there will be a unitary model of commissioning support for the clinical commissioning groups. The second part of our relationship with them, of course, is quasi-regulatory. In other words, we are responsible for ensuring that things go right and, in what we hope will be exceptional circumstances, to intervene when things go wrong. They, like us, will be governed by the outcomes framework for the NHS, which will inform the mandate, but we are also working with NICE to develop a clinical outcomes framework which will populate a number of the indicators to ensure that we get the best possible outcomes. All of this is immensely challenging, and it denotes, as I said earlier, a huge culture change. We're on the board committed to that. We have started something which I'm told is not only unusual, but perhaps unique in the history of the NHS, which is that, albeit as a national body, all our meetings are in public and webcast. For those of an obsessive cast of mind, I can recommend nothing more entertaining than to tune in to a webcast meeting of the National Commissioning Board. But you see, it sounds light-hearted, but the symbolism is immense. This is a public body, publicly facing, publicly accountable, and determined to ensure that we use modern methods of communication. We are in the process, I hope later this week or next week, in appointing the last of our national directors who will be around patient insight, engagement in informatics. I see the use of data as something which can transform the whole way in which the NHS works. And we need to do what we can to break down the historic barriers that have made the NHS rich in data and poor in its intelligent use. Finally, what will we do with NICE? Well, we shall, of course, embrace it with great warmth. But beyond that, the new structure of the NHS establishes a number of arm's-length bodies, all with their own legally defined competences. That's fine, that's what the law says. But it's not going to work unless we have a close and well-developed partnership between us, from the highest levels right through our respective organisations, with NICE, with Monitor, and with CQC, with Health Education England, with Public Health England. The future rests in our hands, not in the hands of the politicians. One of the critical areas for us in working in partnership with NICE is to ensure that their quality standards and their quality advice doesn't go unheeded, that we work with them to identify where innovation can be brought into play across the NHS, to ensure that the so-called 17-year rule from the time somebody has an idea to the time that it's run out across the whole of the system is a relic of the past, and we produce a responsive and innovative NHS. Because only by doing that, frankly, can we pull off the trick, which is a patient-centred, clinically led NHS run on a tightly limited budget, focusing on real value to patients from healthcare. Thank you.